I want you to think back to the appointment where everything changed. Maybe you had just had your cholesterol checked. Maybe you had already had a cardiac event and you were there for the follow-up. Either way, at some point in that conversation, a prescription was written. Lipitor, Crestor, Atorvastatin, Rosuvastatin, Simvastatin, and your doctor told you, quite rightly, that this medication would help protect your heart, that it would lower your LDL cholesterol, that the science behind it is solid. All of that is true. And I want to be clear about that from the start. But here is what most doctors do not have time to explain in a 15-minute appointment. The same mechanism that lowers your cholesterol also quietly lowers something else, something your leg muscles depend on every single night. And if nobody told you to replace it, your legs have been paying the price ever since. I am Dr. Mary, and today I am going to show you exactly what is happening, what the research says, and most importantly, what you can specifically do about it, without touching a single medication. If you are over 60 and you have been on a statin for 2 years, 5 years, 10 years, I want to ask you something honest. Have your legs changed since you started that medication? Not dramatically, not overnight, just gradually heavier, slower to warm up in the morning, tired by early afternoon when they never used to be, and maybe, somewhere between 2 and 3 in the morning, a calf that locks up so hard it wakes you from a dead sleep. You mentioned it to your doctor. You were told it is part of getting older. Stretch more, drink more water, take magnesium. You did all of that. And the cramps still come back. Here's the part nobody explained. The timing is not a coincidence. For a very specific biological reason, statins and leg symptoms are connected, and that connection runs through one compound that sits at the center of how your muscle cells produce energy at night. Stay with me, because I am going to walk you through this in plain language. No medical degree required. By the time this video ends, you will understand what is happening in your legs more clearly than most people who have been living in them for 60 or 70 years. I want to tell you about a man I will call Robert. Robert was 68. He had been on Atorvastatin Lipitor for 7 years, prescribed after a mild cardiac event in his early 60s. He was a walker. 2 miles every morning without fail. It was the thing that kept him feeling capable, feeling like himself. Around year 4 on the statin, something shifted. His legs felt different. Heavy, like he was pushing through water. His morning walks started ending at the 1 mile mark, not because he was short of breath, but because his legs simply would not carry him further. Then the nighttime cramps started. Right calf, almost every time. 2:30 in the morning, his cardiologist ran a full blood panel. Everything came back normal. His CK levels, the standard muscle marker, were not elevated. He was told there was no muscular problem and to continue the medication. Robert began to accept that he was simply aging faster than he had hoped. But here is what his blood panel did not show. What no routine test had ever measured. His CoQ10 levels had been slowly declining for 4 years, and CoQ10 is not a minor detail in how your muscles work. In the cells of your legs, it is everything. I will come back to Robert. But first, let me show you exactly why. Every muscle cell in your body contains tiny structures called mitochondria. You may remember them from biology class as the powerhouse of the cell, and that description is exactly right. Mitochondria take the fuel from your food, glucose and fatty acids, and convert it into APP, the actual energy molecule your muscles run on. CoQ10 is the critical electron shuttle inside that process. It moves electrons along the mitochondrial membrane in what is called the electron transport chain. Without it, that chain cannot complete its work. Your mitochondria cannot produce APP at the rate your muscles need. Here's the clearest way I know to picture it. Imagine a generator with a full tank of fuel. The tank is topped off. The engine looks fine. But the ignition wire has been cut. The fuel is there. The machine is there. But nothing fires. That is what CoQ10 depletion does to your leg muscle cells. Not dramatically, not all at once, but steadily, over months and years, the engine becomes less and less able to produce the power it needs when it needs it most. Now here is where statins enter the picture, and this is the biology your cardiologist almost certainly did not walk you through. Statins work by blocking an enzyme called CoA reductase. That enzyme sits at the start of a pathway called the mevalonate pathway, and that pathway is responsible for producing cholesterol. Blocking it is the entire point of the medication. But that same pathway is also responsible for producing CoQ10. When statins block CoA reductase, they slow cholesterol production, which is exactly what they are designed to do. But they also slow CoQ10 production at the same time. Not intentionally, not as the goal, but as an unavoidable biological consequence of blocking that shared pathway. A 2025 study published in the International Journal of Molecular Sciences by researchers who measured CoQ10 levels directly in patients newly started on statin therapy confirmed that statin treatment causes measurable decreases in CoQ10 in both serum and muscle tissue, and that this reduction may contribute to the musculoskeletal side effects many patients experience. And a meta-analysis published in the Journal of Nutritional Science in October 2025, reviewing 7 randomized controlled trials with 389 statin-treated patients, found a statistically significant reduction in statin-associated muscle pain after CoQ10 supplementation, with meaningful improvement in muscle pain intensity scores. This is not a fringe hypothesis. The connection between statin use, CoQ10 depletion, and muscle symptoms is one of the most studied drug-nutrient interactions in cardiovascular medicine. And yet, for the majority of patients on statins, nobody mentions it. Now, you might be wondering, if CoQ10 is low, why do the cramps happen specifically at 2 or 3 in the morning? Why not during the afternoon when you are most active? That is exactly the right question. And the answer explains something Robert could never figure out on his own. During the day, your circulation is active. Blood is moving. Oxygen and nutrients are reaching your legs continuously. Your body can compensate, at least partially, even with reduced CoQ10. You may feel heavier than before, slower to recover, but you can function. At night, that changes completely. When you are lying flat, blood flow to your extremities naturally decreases. Your metabolic rate drops to its lowest point. Your muscles are at rest, which means they have no active circulation helping them compensate. And that is precisely when a CoQ10 depleted muscle cell has the least capacity to handle any unexpected demand. If that calf muscle is asked to contract a shift in position, a drop in body temperature, the natural micro-movements of sleep, and the mitochondria cannot produce enough AP to complete a clean contraction and release. The muscle locks. That is the cramp, not a random event. A predictable consequence of an energy-depleted cell being asked to fire without the fuel to finish the job. And here is where the age piece becomes critical, because this is the part that explains why the problem gets worse over time, even when nothing else changes. Research published in the journal Antioxidants and confirmed across multiple aging studies has established that CoQ10 synthesis declines naturally with age, completely independent of any medication. The cells that produce CoQ10 endogenously become less efficient as part of normal biological aging. And a clinical perspective from the National Lipid Association, published in the Journal of Clinical Lipidology, found that older age is the single strongest independently associated risk factor for statin-associated muscle symptoms after adjusting for every other variable measured. What that means in practice, the same statin dose that caused no muscle symptoms at 55 may cause real, noticeable nightly symptoms at 65 or 70. Not because the drug changed, because you changed. Your body was already producing less CoQ10 than it used to, because that is what happens after 60. Then add a medication that further suppresses that same production pathway. The gap between what your leg muscles need and what they are getting widens every year. This is why so many people on statins feel completely fine for the first few years and then gradually notice their legs declining without any new diagnosis, without any change in dose, without any explanation from their doctor. The explanation is CoQ10. And now you have it. Now let me bring Robert back, because his story has a second half. After learning about the CoQ10 connection, Robert brought it up with his cardiologist. His doctor agreed it was worth trying. He started CoQ10 supplementation alongside his statin. Within 6 weeks, the nighttime cramps that had woken him for 3 years had reduced significantly. And his morning walks, the 2 miles that had shrunk to 1, slowly came back. That is not a miracle. That is biochemistry working the way it should when you give it what it needs. Before I tell you exactly what the research supports, I want to say this one more time clearly. Do not stop your statin. Do not reduce your dose. Do not change your prescription without your doctor's involvement. Statins protect your heart. That benefit is real, and it matters. What we are addressing today is restoring what the statin takes, not removing what the statin gives. Here's what the clinical research supports. The trials that showed meaningful reduction in statin-associated muscle pain, weakness, and cramping used CoQ10 doses ranging from 100 to 300 milligrams per day. Most participants saw measurable improvement within 30 to 90 days of consistent daily use, which matches what most people experience in practice. CoQ10 is fat-soluble, which means your body absorbs it dramatically better when you take it with a meal that contains fat. Olive oil, eggs, avocado, nuts, any full meal with dietary fat, that is all you need. Taking it on an empty stomach or with a fat-free meal significantly reduces how much you actually absorb, regardless of what the label says. On the question of form CoQ10 is available as ubiquinone, the oxidized form, or ubiquinol, the reduced active form your cells use directly. A study in adults over 60 found that ubiquinol produced significantly higher blood levels of CoQ10 at the same dose. Because the conversion step your body uses to activate ubiquinone becomes less efficient with age. For most adults over 60, ubiquinol in a soft-gel formulation taken with a fat-containing meal is the most practical choice. Now here is the one thing about timing that almost nobody mentions, and it may explain why CoQ10 has not worked fully for people who have already tried it. Most people take their statin in the evening and their CoQ10 in the morning. For many people, splitting the CoQ10 dose half with breakfast and half with dinner provides more consistent coverage throughout the day and into the evening hours when your legs are most vulnerable. Talk to your doctor before starting CoQ10. Bring this up specifically, by name. Tell them you want to discuss CoQ10 in the context of your statin prescription, and ask whether it would be appropriate given your full health picture. Tomorrow morning, when you take your statin, put a note in your phone for your next doctor's appointment. Ask about CoQ10. That is one action. 30 seconds. And it may be the most important thing you do for your legs this year. 3 things to carry with you. 1. Statins block the mevalonate pathway to lower cholesterol, and that same pathway produces CoQ10. This is a documented, peer-reviewed consequence of how the medication works. It is biology. 2. Age compounds this effect. Your body naturally produces less CoQ10 after 60, completely independent of any medication. When you add a statin, the 2 depletions combine and older adults are the most vulnerable to the result. 3. CoQ10 supplementation does not replace your statin. It restores what your statin takes away. The research is real, the mechanism is understood, And the conversation is yours to initiate with your doctor now that you have the language to do it. Now I want to leave you with something before next week. Everything we covered today is true, and it is important. But there is a second layer to this story that most people never reach. CoQ10 does not work alone inside your mitochondria. There is another compound one that CoQ10 depends on as a direct partner in the electron transport chain that is also depleted by long-term statin use through a completely different mechanism that has nothing to do with the mevalonate pathway. When this compound is low, CoQ10 cannot do its full job. The electron transport chain is incomplete. And if you have been taking CoQ10 for weeks or months and felt only partial improvement in your leg symptoms, this may be exactly why. It is not on most people's radar. It is rarely tested, and it may be the missing piece that explains why some people restore fully and others only get halfway there. In next week's video, I am going to tell you exactly what it is, why it matters alongside CoQ10, how to find out if you are already low in it, and what to do about it. Subscribe so you do not miss it, because if what I shared today finally made your leg symptoms make sense next week is the part that completes the picture. I will see you then. Take care of those legs.